Bismillah ar-Rahman ar-Rahim. Dear colleagues and friends, it gives me a great pleasure to welcome you all in this third webinar of Ain Shams Orthopedic Department series of webinars in our online education task. Since 1950, when Ain Shams was founded, we are collaborating with all international societies and universities all over the world. And all through this timing, pediatric orthopedic had a great share in all our activities. We started our learning curve with our great professors, Professor Dr. Mamdouh Hifni, Dr. Al-Ghawabi, Professor Dr. Nabil Khalifa, Allah yarhamuh, and extended until Professor Dr. Hani Hifni. All of them have shared in the learning curve of great surgeons in this subspecialty. Today, our webinar today is DDH, is best practice guidelines. I hope you have a good day and you have very good cases today with our speakers and our panel. So I hand the microphone to our moderator, Professor Nabil Ghali, to start our webinar. Professor Nabil.
Bismillah ar-Rahman ar-Rahim. Thank you, my chairman, Professor Amr Khairi, for me. It is an honor to be with you tonight in this third webinar of Orthopedic Department at Ain Shams University, presented by our Pediatric Orthopedic Unit. We will discuss an important subject which has a great challenge in decision making, which is developmental dysplasia of the hip. First of all, I am Nabil Abdulmenem Ghali. First of all, I would like to welcome my professors and the guest panel of this webinar, Professor Ali Ibrahim, Professor Hani Hifni, and my dear colleague, Professor Tariq Hassan. Also, I welcome my colleagues who will be the speakers tonight, Dr. Tamer Fayyad, Dr. Shadi Samir, and Dr. Ahmed Saeed. Our webinar tonight will be divided into 5 parts. Each part will involve or contain an important title or according to the age of presentation of the child who presented with developmental dysplasia of the hip. Let us to start with part 1 with the early detection. We are speaking about the screening versus surveillance. We present 2 clinical scenarios at age of birth. The clinical scenario with a female, 24 years old, prima gravida, deliver full-term baby girl with elective cesarean section because the baby was in breech position. You are called by the attending pediatric physician as he noticed that the baby has clicky left hip on routine examination of the newborn. This is one of our first clinical scenario. There is another clinical scenario with a female lady, 32 years old, delivers her third baby, who was full term, delivered by normal vaginal delivery. Again, you are called by the pediatric physician who attending this labor as he noticed the baby has clicky right hip. So we have two different clinical scenarios, and one of them, as I mentioned, and I start with asking our Professor Rahim about his opinion, how he will deal with both cases. We start with the first one in front of you, Professor Ali.
Yes. Actually, these two are very clear cases. I would like to mention first that clicking hip is not a diagnosis of DDH. There are some differential diagnoses. Most commonly is iliotibial tract snapping or iliopsoas snapping or associated multiple congenital deformities. So in this case, we have to be clinically sure about DDH diagnosis. The first case is a newborn breech presentation female with a click on the left hip, and it is the first baby for that mother. All these are risk factors for DDH, especially if associated with club foot. So we have to clinically prove if it is unstable hip or not. This we can do by performing ortolani test and Barlow's test. With this, we can find out unstable hip. We can be sure about this by performing an ultrasound examination. Ultrasound examination, although some authors prefer to do immediately after birth, myself, I prefer to do after 6 weeks, because in the differential diagnosis, we have to put a normal hip, which gives a click without being unstable hip. Thanks.
This is the first case, Professor Ali. What about in comparison with one?
The second case does not have risk factors because it is a boy, it is the right hip, and it is the third baby for that mother. So, because there is a clicking hip, we have to be performing other clinical examination, including Barlow's test and ortolani test. And in this case, we can do ultrasound at birth or delay it for 6 weeks. And myself, I prefer to do X-ray to examine the spine to exclude meningomyelocele and paralytic hip and other causes of clicking hip.
This case, Professor, second case has an isolated problem. The other parts, examination part, are normal. Do you notice that the first one, there is a risk factors, as you said, and second one, there is no risk factors. And you will proceed for doing ultrasound.
Yes.
For both?
Especially
for both cases? Yes.
Especially for the second case. Especially for the second case. Because for the first case, there is risk factors, and we can perform a clinical examination to be sure about instability of the hip, which can be normal and will disappear at 6 weeks.
Okay.
So I prefer myself to do for the first baby ultrasound after 6 weeks. Okay. And if I do it immediately, I have to repeat it at 6 weeks.
This is your opinion, Professor Ali. I can shift my mic to Professor Hani to tell us about his experience in these two cases. What is your protocol of proceeding for diagnosis and treatment, Professor Hani, for these cases?
Thank you for inviting me, Professor Nabil and Professor Am. Thank you very much. It's my pleasure.
Welcome, as usual.
I think, as Professor Ali said, the case with the primary gravida has a lot of question marks. So she needs to be properly examined. And if we have any doubts, we can do ultrasound either before she leaves the hospital, but there is no way to pass the 4 weeks mark without having a proper ultrasound and document whatever is there. If she is positive, or we click, if the baby is query dislocatable, I would put the baby in double nappies for the time being until we do the proper ultrasound at the proper time, which could be either before the hospital discharge or before the 4 weeks mark. The incidence of success at for the ultrasound at the 4 weeks mark is 80% to give you good results. So I wouldn't miss that time. The clicky hip for the other boy is not really showing a lot of question marks. So I would say that this could be iliotibial band clicking or either this. Yeah, I mean, this is what is expected in this age.
What is your opinion, Professor Hani, as regards the rule of ultrasound, as we see in some countries, they do an ultrasound examination as a routine screening for any newborn in their hospitals, while other countries did not depend on it as a screening and only ask it for doing ultrasound for babies with risk factors. Do you believe of that?
There's countries like Germany, they do ultrasound immediately after birth. Some centers in the UK, they do that, but the studies did not show much difference really having the ultrasound very early or at the 4 weeks mark. But even if you have the ultrasound showing dysplasia of the hip at 4 weeks, you have to follow it up definitely. But even if you don't have any positive data with the ultrasound at the 4 weeks, but the history is suggestive, you have really to follow up the child until you reach a safe stage.
Okay, Tarek, Professor Tarek, I have one question for you as regard if you present this case without hip problem and you have a boy or baby with foot deformity, you will ask for a screen ultrasound examination as regard to evaluate other congenital anomalies, although the clinical examination is negative of the hip joint?
No, my protocol for screening is the selective screening. What I do is that I always advise that any baby should be examined clinically very well with the Barlow and Ortolani, like Professor Ali and Professor Haney said. And if in doubt, by the pediatrician, by a trained pediatric orthopedic surgeon. And I only would do an ultrasound at the age of 6 weeks, even if I have the risk factors like in the first case scenario, even if she had club foot or whatever. The other thing I disagree with Professor Ali about is that I would never do an X-ray, because if I would like to detect meningomyelocele, etc., I can detect it clinically, even sacral agenesis, etc. So the X-ray will expose the baby to a hazard of X-ray that is not needed, and it will not give me the diagnosis. I will be able to diagnose any meningomyelocele clinically.
Thank you, my panel. Okay. Now we shift to Dr. Shadi, who will tell us what we need to know about this problem at this age. Yes, Shadi, please.
Thank you, sir. I think the first problem to talk about is the difference between clicking hip and a clunk, which we can use to diagnose DDH. A clunk is a feel of motion. We feel a motion under our hand and even may see it during perforation of Ortolani and Pablo test. That's first. Second, imaging. We depend on ultrasound in early screening for DDH because X-ray does because in the first 6 months the femoral head is not yet ossified. So the advantage of ultrasound is non-ionizing radiation. I can visualize the cartilaginous femoral head, and the disadvantage is an operator dependent and need a relaxed hip to do it. Okay. Okay. As you can see here, this is the first. Okay, the hip ultrasonography can be universal or selective, and this is a debatable issue. Also, it can be done at birth or at the age of 6 weeks. Also, another debatable issue. And another debatable issue is ultrasound and clinical examination in the first 6 weeks enough to exclude DDH in newborn, because we know that stable hip at birth may become unstable later on, or unstable hip at birth may stabilize at the age of 6 weeks. These are debatable questions, and we try to answer them. As we all know that screening tests should be very highly sensitive and specific, resulting in nearly no false positive or negative cases. But there is no ideal screening test for DDH until now. We depend on surveillance and doing clinical examination and ultrasound examination. Both are important and should be done and should be repeated. Next, please. Okay. Our first clinically proved evidence that we know that Germany and Austria, both countries adopt universal ultrasound screening, regardless of the clinical risk factor. On the other hand, United States and United Kingdom perform universal clinical screening for all neonates and selective ultrasound screening only for high-risk patients or patients with positive ortolani and paro tests. In all these countries, ultrasound usually done between 4 and 6 weeks of age. Okay. Okay. Also, it is universal acceptance that ultrasound has reduced the number of late presenting cases and shortening the treatment time and decrease the number of surgical procedures of the hip joint. Okay. But there is an important question: universal ultrasound has it discovered DDH? It was found no. There's no difference, no statistical difference between screening specific screening ultrasound and universal screening in detecting or preventing late presenting DDH. Okay. Also, the earliest reliable time for ultrasound screening is the 4th week after from the start of the 22 days and beyond, because in the first 3 weeks there is maybe minor morphological changes and instability in the hip joint that may appear as dysplasia, and patient may undergo unnecessary treatment with financial burdens for him. Okay, so what to do in the early diagnosis and surveillance for DDH? First, all neonates should undergo clinical examination by paro test, and selective ultrasound should be reserved for patients with high risk factors or positive test. It should be done from the age of 4 to 6 weeks. If ultrasound is positive, we will proceed for treatment. If negative, this doesn't mean that the patient is cleared. It should be followed up by clinical examination until walking age.
Okay, thank you, Professor Shadi.
Thank you, sir.
Now we finished part 1 is the screening and what we do in the first 6 months. Now we shift to part 2 of our webinar is the treatment within the first 6 months of life. Also, we present clinical scenario with baby girl referred to you with a 2 weeks old and clicky right hip is detected during routine checkup. She requested by her pediatric physician to do ultrasound, which was reported as grave type 3, means complete dislocated hip. You did an examination of her and you detected positive ortolani test. Another clinical scenario that 6 weeks old girl referred again to you by her pediatric physician because he detected also light hip click during a routine checkup. She requested ultrasound, but the difference is the presence of dysplastic hip, which is grave type 2C and not complete dislocation. And when you did a clinical examination, you detected a positive ortolani test. What is Professor Tariq discuss with me how you proceed for treatment of such 2 cases?
Okay, first of all, now this baby is now has a positive ultrasound, just dysplastic, okay, and she's 6 weeks.
This is the second one, Tariq. First one, 2 weeks with complete dislocated hip by ultrasound.
Okay, so we'll discuss the first one.
Yes.
Weeks old. Going back to my to the question I answered before, I would just document the clicky hip on my examination. I will detect if this click is just a click like the pediatrician said, or it is actually a clunk, so I know whether there is a positive ortolani. If there is no positive ortolani, I will do a provocative test, which is the Barlow test, and try and dislocate the hip and then relocate it again. Document all this, but I would still not do an ultrasound except at the age of 6 weeks. My argument for this is that this baby might stabilize with time. So at the age of 6 weeks, I will do the ultrasound. And there is no point in doing an ultrasound at the age of 2 weeks because I will not treat. Now, I believe that any imaging or any investigation that doesn't lead to a change of the treatment plan is useless. It's an overuse of the resources and it just gives the false sense of worrying. So I will just document and tell the parents that there is a serious problem that needs to be rechecked at the age of 6 weeks. And then at the age of 6 weeks, depending on what I find, I will treat.
This is the first one. As regard the second baby, 6 weeks old, and he is presented with you as an ultrasound showing this plastic hip.
Okay. Now, this is very debatable because this hip is just dysplastic. It is not dislocated. There is no direct evidence that wearing the pelvic harness will improve the dysplasia, and there is no direct evidence even until now that a minor degree of dysplasia, such as this one detected at birth, will end up in late osteoarthritis. So again, I would be very reluctant to put on a pelvic harness, which is very disabling. I will give a further chance for this baby and repeat the ultrasound after another 3 weeks. And then if the dysplasia is improving, I can just carry on. If the dysplasia persists in spite of reaching the 9 weeks or 10 weeks, then I will reluctantly put on the pelvic harness for a very short period of time and follow it up very soon and make sure that the dysplasia is improving. So I'm not really concerned very much at the dysplasia. But if this scenario would be the opposite, so 6 weeks and the dislocated hip, then I would definitely put on the harness as early as 6 weeks.
So you will depend on the age at time of presentation, not on ultrasound examination.
Yes, and also because the ultrasound, as you know, is operator dependent. So if you get two trained pediatric musculoskeletal radiologists and ask them to measure, you know, the graph staging is depending on the alpha and beta angles, and they are numbers. And the person who draws the baseline and draws the alpha angle and the beta angle, it's a human person who puts the markers and then just measures the angle. So maybe the same person, the intra and inter-observer errors are very, very high in this. So the same person might measure the same angle twice as 55 and once as 50 and once as 60, and two radiographers may measure them different values. So I'm not
how can, Professor Tara, we solve this problem, as you said, that it is an radiodiagnostic dependency factor? Is there any other modality for the evaluation and to confirm the diagnosis of such cases at that age?
No, not at this age.
Yes.
I know you're trying to attract me to talk about the role of MRI, etc., but not at this age and not for this reason. MRI we might discuss later when we want to check out the concentricity of our reduction. But
Okay.
at this stage, the only investigation, unfortunately, that you can depend on, and I say unfortunately because it is operator dependent, and I say it's very variable. So I'd only be concerned if at 6 weeks I have a dislocated or dislocatable hip, and I will put the pelvic harness on immediately. If it's just dysplasia, I will give another 3 weeks, and then if the dysplasia persists, then I will very reluctantly put on the pelvic harness for a short duration of time and then scan.
I want to hear the opinion of Professor Hani about these two cases. This first case, 2 weeks with positive, complete dislocated hip. What is your opinion, Professor Hani? Professor Hani? Okay, Professor Hani disconnected. I think Professor Ali with me.
Yes.
What is your opinion, Professor? Dr. Hani, okay? Return back,
Yeah.
please, Professor Hani.
In 2 weeks age, the diagnosis is not settled, whatever it is. Diagnosis of dislocated hip is not really causing a major problem because we know that it can relocate and it can go on without any problem. But I would try to really relocate the hip and put a double nappies on at this age. I know it's not really going to help a lot, but at least this is not causing any harm.
Okay, what about the baby with 6 weeks with dislocated by ultrasound? Do you leave him like first one, or you proceed for application some diapers or pelvic harness?
In 6 weeks' time, I would put double nappies and recheck again in 3 to 4 weeks. If it's not improving, I would put a Pavlik harness, as Professor Tariq said. But I wouldn't leave the hip as it is without any interference, knowing it is dislocatable. I would put a double nappies on. It's not going to cause any harm. It may help a lot. At least the parents would know that they are on the line of treatment.
So, on basis of these two cases.
Panel, Dr. Nabil, please, for the panel who's talking, can open the video, please. For the panel who is talking,
okay.
he must open the video, okay?
Okay, Professor Amr. Return back, Professor Hani. You asked when you will ask for application of the Pavlik harness as regard these two cases. You first one follow up and second one double nap because it is not dislocated. But I assume that the 6 weeks old baby has a complete dislocated hip. Do you advise to do a Pavlik harness? Plenty?
Yes. In 6 weeks' time, I would start treatment immediately. I put Pavlik harness, carry on, and follow up with ultrasound every 3 weeks until everything is settled down.
So you apply Pavlik harness for this baby, and you do an ultrasound follow-up.
Yeah.
First ultrasound immediately after application of the Pavlik, and you found that the hip is not contained. What will do?
I would leave the Pavlik harness as it is and follow up with the ultrasound, because Pavlik harness takes a little bit of time for the hip to be relocated. I'm not expecting as soon as I put the Pavlik harness on that it will relocate. It will take some time. So my role is to carry on the follow-up until it is relocated, and then we'll continue the follow-up afterwards.
Okay, assuming that at the end of the 3 weeks you do an ultrasound for the hip and it is not concentrically reduced, and the baby now is 12 weeks of age, do you proceed for another line of treatment for this baby or leave him?
12 weeks is not a very late time. I mean, you have to give a time for the Pavlik harness to work.
But you did an ultrasound and the hip is not contained. You still persist.
If there's no adductor tightness, there is no adductor tightness, I would wait. I may change the Pavlik harness straps itself, increase the flexion, increase the abduction gradual. There is a way you can play with the Pavlik harness. You can increase the flexion gradually from 70 to 90 to 120 degrees flexion, and then start abduction. So this can help. It's not a splint, you can put it and leave it. It's a dynamic splint. So you can play with the Pavlik harness until you reach whatever you think is the proper reduction.
Okay. Professor Ali, I want to ask you about the Pavlik. What are the precautions or requirements you put in mind during application? 2, aiming for concentric reduction of the hip, number 1. Number 2, to avoid the complication which may take place with this Pavlik harness.
Yes, actually, I would apply Pavlik harness even in this plastic hip because it is a lively splint and dynamic, and it will enhance the development of the hip, even if it is only dysplastic. That point I disagree with Professor Tar. Flexion, and we should not do too much abduction. We have to keep the hip in a safe zone of movement to avoid AVN, and this is a great complication for the baby.
Yes.
And to avoid also femoral nerve compression and ulceration of the skin if the flexion.
Okay. So, Dr. Habib, return back to Professor Tariq. If
we agree very near to each other, if it is too much flexion, another point, if the flexion, it can cause inferior dislocation of the hip.
Yes.
So we have to keep to keep the active movement in a safe zone, and to avoid too much abduction and too much flexion.
Okay, thank you. Professor Tariq, If we decide and assuming that the hip is contained and concentrically reduced in the public, how long do you leave the baby in the public harness to reach the final containment and reduction of this hip?
Okay, excellent question. Just before I answer it, I just want to add one little piece of information. The Pavlik harness is very, very difficult and cumbersome to be worn by the baby, and it causes a lot of distress to the parents to look after the baby in the harness. That's why I would not apply it unless it is really necessary. That's why even in just this plastic hip, I'm very reluctant to put it on until giving a further chance. And also when I put it on, like Professor Haney said, we do not expect immediate reduction. It should reduce gradually. But what I disagree with is that if after 3 weeks of wearing it, it doesn't reduce, then I know I announce the failure of the Pavlik harness and I discard it and I decide on another treatment. Now, going back to your initial question, which is how long to wear it, I advise the harness to be worn, very simple rule, as long as the age of the baby at the time of wearing it. So if the baby wears it when she is 6 weeks, then she has to wear it for 6 weeks, day and night, continuously, with only half an hour allowed to be taken off for bathing of the baby, and then it should be reapplied. And then after this, I start to wean it off gradually in a similar period of time. That's why when the hip is really dislocated and I want the benefit of the Pavlik harness, it is best to wear it at the age of 6 weeks, which is very young, because this means that the baby will wear it for 6 weeks completely and then get weaned off it in another 6 weeks. But if the baby is 3 months at the time of wearing it, then you have to wear it for 3 months and then wean off in another 3 months. And then you start going past the 6-month age, in which the baby wants to sit up, wants maybe even to crawl in some babies. So it's really very, very difficult for the parents to comply with.
Okay, thank you. Now we shift to Dr. Ahmed Saeed, who tell us what we need to know about the requirements and the shape or method of application of this Pavlik harness. Please, Ahmed.
Thank you, Dr. Nabil. We would like to confirm the idea of Pavlik harness in treatment of baby before age of 6 months, and we aim to make a concentric reduction of the femoral head inside the acetabulum by using the Pavlik harness, and avoiding the most common complication, which is the avascular necrosis, as we will show. Okay. The most important two straps used in Pavlik harness is the anterior or flexor strap and the posterior one. We have chest strap and the two shoulder strap, leg straps, and the most important is the anterior flexor, which used for or to flex the hip, and the posterior strap, which used to prevent the adduction of the hip. Not to making two flexion or two abduction, but it to prevent extension and adduction. So it is a dynamic straps, not a static straps, and not a rigid or a stiff instrument. Okay. Hip is flexed to 90 degree or 100 degree of flexion, because more flexion will cause posterior or inferior dislocation of the hip, and they may cause femoral nerve palsy. So we don't flex the hip beyond 100 or 120 degree of flexion. Also, abduction is used within the safe zone of Rams, making a maximum abduction, then decreasing the abduction for 45 degree, because more abduction will cause an AVN or avascular necrosis. And when we put the hip in neutral position, it will dislocate the hip. We should, like our professor said, we should investigate or make sure that the hip is contained inside by making ultrasound weekly. Each time we should examine the stability of the hip by doing Barlow and Ortolani test. Okay. Then, okay, Dr. Nabil. How time or duration of wearing the Pavlik harness? Duration, we make the public harness or put the public harness all day time, 23 hours, and make it off for 1 hour to make bathing or to make anything for the baby. Till the age or till the time that the hip reaching the stability by Barlow and Ortolani test and by the ultrasound, all of this confirmed that the hip reaching the stability, then we could put the public harness for more 3 months after gaining the stability. And after that, we go with gradual weaning of the public harness. The most common 2 complications which we should know, avascular necrosis when we make maximum abduction in public harness, and the public harness disease, which is debatable as we see in the literature. Public harness disease, when we put public harness on a dislocated hip for more than 3 to 4 weeks, it will erode against the superior lateral acetabulum and causing eccentric loading and eroding the superior lateral acetabulum. So after a while, we should discontinue the public harness to avoid such a complication. Indications of the public harness, as we said, below 6 months and reducible hip. And the contraindication if the head is not reducible, like syndromatic hip dislocation or stiff hip, or in the case of paralytic hip dislocation. When we see the review of literature, which is the most important, in Journal of Children Orthopedic, an exciting paper published that said, after the age of 6 months, it is difficult to immobilize the larger and increasing active child with public harness type. So you must not wear the public harness after the age of 6 months. The upper age limit is 6 months age. Adler et al. Publishing in SICO, International Orthopedic, and recommending also not to use the public harness in syndromatic hip dislocation like arthrogryposis or neuromuscular hip dislocation like spina bifida or cerebral palsy. So he put the indication for public harness only the congenital or developmental hip dislocation, not neuromuscular, not syndromatic hip dislocation. Sanker et al. Putting a very nice article in GBO, which support the idea of Prof. Hani Hefni. About he examined 38 patients with dislocated hip in public harness. And he followed these babies for longer duration to see if the dislocated hip inside the public harness and they continue more than 3 weeks, they really causing superior lateral acetabular eroding and really causing a public harness disease. He concluded that 80% of the hip in public harness treatment who successfully put in the public harness, although dislocated, they relocated again and the hip is relocated inside the acetabulum for 14 weeks. So he recommends using a public harness in infants up to 14 weeks, nearly more than 3 months, even the hip is dislocated. And he reported that there is no any public harness disease occurred or posterior superior erosion occurred in the acetabulum, as he using alpha angle as indication of the acetabular dysplasia or bony acetabular dysplasia by ultrasound. So he recommended to use public harness even in dislocated hip in more than 3 to 4 weeks, up to 14 weeks, and no fear of public harness disease or erosion of the acetabulum. Thank you.
Let me, Ahmed, to ask you about one question that you asked us. Public harness is not advised to be weared after the age of 6 months. Why?
Because the baby will be get more larger and more stronger. He need to crawling, and increasing activity during crawling make it very difficult to put the public harness. So he will need to extend the hip, to adduct the hip, to making the crawling. So increasing activity and body weight of the baby, making the failure rate of public harness is very high. So we need weight under age of under 6 months and controllable baby, no increasing of the activity or making crawling.
Thank you, Ahmed. Now we shift to part 3 of our webinar tonight is the treatment after the age of 6 months. Also, we will present a clinical scenario cases and discuss with our panelists and speakers how we can solve these problems. This clinical scenario that we have a girl, old baby, 7 months age girl presented to you because her mother noted shortening and limited abduction of her left hip. And you did an examination and shown in the figures that she has limited abduction and shortening of the left lower limb. This one scenario, put in mind that the age is 7 months, and you asked for a plain X-ray for this girl. Now I will ask Professor Hani, how, sir, you can proceed for management treatment of this girl.
Thank you very much, Dr. Nabil, for asking me. On examination, as you can see now, the hip is clearly dislocated. And I think at the age of 7 months, we have to rethink again about having a closed reduction by trying adductor tenotomy, checking under image intensifier if this can be reduced. And if it's reduced, fine, we put the public harness on, a spiker on. There is a lot of literature now is coming that you can, even with the late presenting children, you can put them in a public harness and manipulate the public harness gradually, and there is no reports for AVN or any problems. And there is a study in Florida done by Chad Price, who is the director of the International Hip Dysplasia Institute in Florida, as he studied the late presenting children between the 6 months and 5 years or 4 years with a closed reduction. What he does is he uses the public harness to increase the flexion until you get the head underneath the acetabulum, below the acetabulum, and hook it in by abduction to reduce. And he's presenting a very good series with a 90%, more than 90% success rate with no AVN or femoral nerve pulse. Actually, he did this on the study done by Papirlo in Greece. And he sent a team to study this there, and he came back with the results, and they are doing this now. We don't have this experience, but I believe in our hands now, we do a closed reduction by adductor tenotomy under image intensifier, but it's a worthwhile to think about this technique again. He uses what is called Hoffman-Daimler technique, modified Hoffman-Daimler technique. Thank you.
You decide to do for hair closed reduction.
Yes.
How can we decide that the head is concentrically reduced after closed reduction intraoperative inside the theater?
Well, actually, we have an experience with this by the image intensifier.
Yes.
AP and lateral view. It is difficult to have a lateral view, yes, but we can do that. Ultrasound is very helpful, but after reduction, you can do an MRI if you want to.
Okay. Professor Tariq, do you agree for that closed reduction isolated, we don't need to do an arthrography for this after closed reduction?
Excuse me. First of all, I just want to pay my respects to Professor Hani, but I would suggest a different treatment. I do not believe at all in the practicality of closed reduction, because to do a successful closed reduction, you need two things. You need to do, as Professor Hani said, an adductor tenotomy, and you also need to do an arthrography. The MRI is a very good way, but it will only tell you the result after you have applied the spica and the child has gone out of the theater. The ultrasound, you will not be able to do once the spica is applied. So the only way you can ensure it intraoperatively is by doing the arthrography. I myself, over the years, I have repeatedly tried to do a successful arthrogram. It is a very difficult technique because you usually put the needle, you inject a little bit of the dye, you find that you're not really intra-articular, then you get a little, you move your needle a milli or two, then you another milli of the dye, and what you end up is that you end up with the whole proximal femur covered in dye, and you cannot detect your medial pool. So what I would do for this baby at the age of 7 months, I would go in and do an open reduction. It is very, very simple, and I would still do it through the anterior approach. I would not go for the medial approach because I find it very difficult, and it has an increased incidence of AVN in the literature. So I would definitely go for an open reduction. And then even when I operate on these babies, I'm not extremely happy at the end of the operation when I look with the image intensifier on the hip spica, because I don't have an ossific center. I just rely on the proximal femur, but then I have to get an MRI, like Professor Haney said. This is a very good way, because actually, if you look at the post-operative evaluation using something like the CT scan, which we usually do in older babies, you have to remember very well that every single CT you do to these babies is equivalent in the millisieverts, which is the unit of radiation measure, to 200 plain X-rays. Yes, 200. So now using the MRI is very good, particularly when you don't have an ossific center.
You you answer my next question, but first, Professor Ali, I agree with Professor Hani that closed reduction is the ideal treatment, and we have lack of experience doing arthrography. But assuming that we did for this girl is closed reduction for her, the image inspires the anteroposterior view, the head is concentrically reduced. But sometimes shin is reduced, everything is okay, but I'm not sure that the head is concentrically reduced because I didn't see the lateral view. How can I judge that, or is there any other modality for evaluating that?
I'm sorry, I was disconnected by the internet.
Okay, if Tariq is heard my question, yeah. Can you answer?
My point of view is to do closed reduction, maybe assisted by adductor tenotomy, and to assess the position after that, we can do either multi-sectional MRI or CT, but to be sure that it is concentrically reduced.
You asked for CT. Yeah. Okay. Another clinical scenario for the same age but older one. We have an old baby, 18 months, was presented with this video. I will show you now. This is the gait of the girl. Okay, and she has a Trendelenburg gait, as we noted, and you ask it for this plain X-ray. Do you change your mind, Professor Hani, for the line of treatment for this girl? She's 18 months.
I think it's not very high dislocation, and it can be reduced nicely. Open reduction will do it fine. So if we put the hip in during surgery and we find it stable, I would leave things alone and do a proper capsule plication and put a spica on. If it is not stable and it needs a femoral problem, needs a varus osteotomy, we'll do the varus osteotomy. If she needs a shoulder osteotomy, we'll do that. But before we go to surgery, we have to have a 3D CT scan to assess where is the problem. Is it acetabular or femoral? In my view, it can come nicely reduced without any osteotomies.
Okay, can you judge about your opinion about the evaluation of the head or the acetabulum by plain X-ray because some places has no CT scan and it is an exposure to radiation for the baby. Can we depend only on this X-ray to confirm
Yes.
what I need to do?
Yes, yes. As I said, it looks like that it can be reduced nicely. During surgery, you can take the decision. If it is stable, you do it after proper application, fine. If not, you do varus osteotomy.
Okay. After that, you will apply a complete cast. For how long, if you did for the girl close reduction, Professor Hani, how long you leave the plaster in the girl? How long time?
For this girl,
Yes.
I would put it 6 weeks and change the spike another 6 weeks, so 3 months altogether.
Okay. Shift again to Tariq. Please, your opinion.
My opinion is that for this baby, I would do an open reduction, full stop. I will not ask for a preoperative CT because it will not change my plan. I'm not going to do any Salter or any femoral osteotomy for anybody under the age of 3 years. So I will only going to rely on open reduction, and the rest is going to come with remodeling. And I do not want to expose the baby to a preoperative CT, which is equivalent to 200 chest X-rays. That will not change my decision. And I'm very confident that this would be reduced only by open reduction, provided the open reduction is done well and the capsulorrhaphy is done correctly and all the steps we know about are done. And I would put her in 1.5 spica for 3 months. And then after this, I will not put any hip abduction braces or anything, just allow her to start moving.
What are the precautions during reduction, open reduction, Professor Tariq, for this girl during open reduction? What are the points the surgeon take care of it to avoid complication of such case?
I think most of us know the steps, but I find that I know this from my experience in doing recurrent cases referred from elsewhere, that the two things that a lot of people forget about. One is dividing the transverse acetabular ligament. And number two is good cleaning of the acetabulum. Now, obviously, there are very basic things that go without saying, like if for example, you get somebody with a recurrent dislocation and the surgeon has not done an adductor tenotomy or has not divided the iliopsoas tendon, for example. These are basic things that if you do, you will not get a concentric reduction and you'll get a recurrence. But the two very critical things that a lot of people find difficult to do, and so maybe sometimes they skip them, is dividing the transverse acetabular ligament and cleaning the acetabulum very well from the pulvinar.
This to give you the chance to concentrically reduce the head inside the acetabulum. But what you must take care of what during reduction? That it will not be tight during reduction. You may need here shortening of the femur to reduce the head. Or
this girl?
Yes.
No, not at all. No.
Okay.
Varus derotation and pelvic osteotomy I will not do before the age of 3. Femoral shortening I will never do before the age of 4 or 5 unless you really have a high dislocation. Never. I will never do this in this baby.
Okay. Let us to shift to another clinical scenario of the same age with older one with 1 month baby, a girl baby presented with not walked yet, and the treating physician suspected DDH. He requested X-ray, and as you see, it is an active rickets. Can you comment on it, Professor Tariq, for this message very shortly? Because it is an everyday work that the pediatric physician sent you limp child with, told him he has DDH, and you do an X-ray, and we find an active rickets. So you must put in mind that the baby has other metabolic, other diseases to exclude rather than DDH. You agree with me?
Yeah, I totally agree with you. And a lot of late presenting babies with DDH have come to me with the opposite situation. They went to their doctor and they are complaining that their daughter is limping on her left leg, for example. And the pediatrician or maybe even the general orthopedic surgeon tells them that, oh, okay, your child has rickets. He doesn't even do an X-ray. He doesn't do labs, and he prescribes vitamin D and calcium, and then the baby keeps on limping until they reach you when the baby is 2.5 or 3 years old. So the message is that DDH by itself is not a cause of delayed walking, and unilateral limping will not be caused by rickets.
Okay. Now we shift to what we need to know about the treatment of this age group before 18 months. Yes, please, Ahmed.
Thank you again, Dr. Nabil. We need to know about closed reduction and hip spica versus open reduction. There is a lot of algorithm to determine when to go with the closed reduction and when to go in open reduction alone, or when to go open reduction with femoral or pelvic osteotomy. A lot of literature putting the algorithm according to the age of the child, and another according to the primary dysplasia, where there is acetabular dysplasia or femoral, like coxa valga or femoral anteversion. Okay. So closed reduction, usually we can do closed reduction up to 1.5 years. After failure of the public harness, after 6 months, up to 1.5 years, you can do closed reduction. But there is a lot of parameter and the precaution to do this closed reduction. It should be done under general anesthesia and using arthrography, and to determine the medial dipole, that the head is fully contained inside the acetabulum, and usually you need to do adductor tenotomy and putting the baby in the spike. If failed or you don't have the parameter to do the closed reduction, you should shift to open reduction. We should differentiate between developmental dislocation of the hip and traumatic hip dislocation. We cannot do simple closed reduction and we relocate the head inside the acetabulum, but in developmental dysplasia of the hip, we have many obstacles, intra-articular and extra-articular. Intra-articular, like the pulvinar fibrofatty tissue, or thickened ligamentum teres and transverse acetabular ligament, inverted labrum, limbus, and extra-articular, like the iliopsoas and adductor tenotomy. All of this should be released to achieve stable concentric reduced hip. After making the reduction, we should do the next important step in the capsulorrhaphy. Most popular is to do T incision or vertical and transverse incision, and advance the superior lateral part of the capsule inferiorly to tighten the capsule anteriorly and making the hip stable, especially if we do open reduction alone. Okay. This is the T incision and the superior lateral capsule. To achieve the satisfactory reduction, either by closed reduction or by open reduction, we should obtain clinically stable hip, and not needing for extreme position like severe abduction or severe flexion or severe internal rotation to relocate the hip. It should be a stable hip, not in extreme position, and intact restore Shenton line and Van Rosen line. And it is difficult to do, like Dr. Han and Dr. Tariq said, lateral view under image intensifier inside the intraoperative period. Post-operative, after closed or open reduction, a hip spica, like public harness, we do it in 100 degree of flexion, 45 degree abduction. If we do open reduction alone, you need some sort of internal rotation. And if there is osteotomy, like femoral derotational osteotomy, putting the head in neutral position. And the total period of immobilization, it is a debatable issue, but the most common and the most practical from 2.5 months till 3 months of duration. And we need to do CT axial cut, especially thin cut, which is showing both femoral head against the triradiate cartilage, and the femoral capital epiphysis is pointing to the triradiate cartilage in this important cut of CT. Okay. Back to the literature, in the Journal of American Academy, which published in 2001, they concluded that children have a successful closed reduction up to 22 months. up to 22 months, you can do a successful closed reduction in DDH. But they put a strict information that they should do arthrography inside the surgery. And they concluded that arthrographic evaluation had significantly less incidence of avascular necrosis when compared with those treated by closed reduction without arthrographic guidance. And if they maintain a stable hip with arthrography, and they make the success if the medial dipole less than 5 millimeter, so the head is concentrically reduced and making the baby in hip spica. And if the arthrography showing unstable hip or more than 7 millimeter of medial dipole, they will shift to another modality of treatment like the open reduction. So they depend on arthrography in evaluation of concentric reduction and successful reduction up to 2 or 1.5 years child. On another side, McEwen publishing an article in Journal of Bone and Joint and concluded that we can do closed reduction without arthrography. We can making another modality to assess the concentric reduction rather than the arthrography, like doing a CT scan, axial cut, post-operative in hip spica. And they depend on the anterior shunt line. Anterior shunt line is a line drawn in this axial cut between the anterior symphysis pubis and the anterior neck of the femur. If the anterior shunt line is resumed, this is considered successful closed reduction. And if there is broken anterior shunt line, like a photo in the left side, there is need another modality like open reduction. So they don't depend on arthrography in evaluation of closed reduction. Okay. This important topic in Journal of Children Orthopedic, they confirm what we said about the position of the baby inside the hip spica, whether after closed reduction or after open reduction, and we should not put the baby in extreme hip abduction, because if we put the baby in extreme hip abduction, it will end up by avascular necrosis. So we need abduction less than 45 degrees. Although hearing in GPO stressed on the total amount of immobilization in hip spica after closed reduction or after open reduction, that the ideal period of immobilization is equal to 3 months, without need to exchange the cast, unless if it is it remain clean and not tight, you cannot exchange the cast in this period of 3 months. Okay. We shift to open reduction. Literature said, and confirming what Prof. Tariq said about the most common cause of redislocation after open reduction is not cutting transverse acetabular ligament. This considered the most common cause of redislocation and revision surgery in DDH. So you should orient it well about the intra-articular and extra-articular obstacles for reduction, especially the transverse acetabular ligament, which is the most common cause. Straker also making a comparative study between, if we do open reduction, can we do a preoperative traction or we do intraoperative femoral shortening? So he compared between both methods, between preoperative, especially in high hip dislocation in older elder child above 3 years age old, and he concluded that if we do preoperative skeletal traction, there is incidence of 54% of osteonecrosis. And if we do intraoperative femoral shortening, the incidence in his literature is 0 for avascular necrosis. So he recommends to do femoral shortening with open reduction if there is high dislocation, especially in elder children above 3 years, and do not recommend preoperative traction to decrease or to make the head at a lower level. Okay. The most important and the most interesting topic or articles is Arslan's in Journal of Children Orthopedic, and I recommend this article for anyone who needs to involve it in DDH surgery, because he make very clear points in this idea. Arslan concluded that the single stage surgical procedure was more economical and allowed more rapid recovery, more than and less complication than consecutive operation. So he recommend a single stage surgery. Second, he have an excellent outcome in his all baby with only doing femoral shortening or femoral derotation or pelvic osteotomy with open reduction without doing any varization. So he answered the questions. Is varus osteotomy necessary in one stage treatment of developmental dislocation in older children? And his answer is no. He didn't do any varization or any varus osteotomy, and he considered that derotation is the key in the femoral osteotomy with or without femoral shortening. And the varus has no role in
احمد انت عامل ميوت يا احمد، الصوت عندك ميوت محدش سامع.
Although the Journal of American Academy confirmed this point of Arslan, that femoral varus producing osteotomy have a role in treatment of children with neuromuscular disease, including cerebral palsy. However, varus osteotomy combined with open reduction has little or no role in treatment of DDH. Our grateful to make an publication that will be published on October 2020 in current pediatric orthopedic, how to determine the type of femoral osteotomy. And this paper is done in Ain Shams University Department of Orthopedic, how to determine the type of femoral osteotomy and management of developmental dysplasia of the hip. We answered this debate according to the following point. Femoral shortening osteotomy is a must in any high hip dislocation. So if we have a high hip dislocation, especially in elderly children, we should do femoral shortening to avoid tight reduction and to avoid avascular necrosis, like Schenker et al. Said in GBO. Femoral derotation osteotomy, FDO, or femoral derotation alone, because a lot of baby, when we make internal rotation, we will see that the neck shaft angle is normal and he has no coxa valga, but it is apparent because of increased femoral anteversion. So we will, when we exclude the femoral anteversion by putting internal rotation of the femur and making the true anteroposterior view, you will see that there is no coxa valga and only excessive femoral anteversion. So in this group of patients that have a normal neck shaft angle below than 140, we do femoral derotation only, and the additional varization is unnecessary and better to be avoided. While if we do this internal rotation and there is increased femoral anteversion, varus derotation femoral osteotomy is done, and we do varization in our osteotomy. But be careful, when varization is done, make a minimal varization as possible to achieve containment and stable hip, because varization make limb length discrepancy, varization make a persistent Trendelenburg sign, varization make residual coxa vara may persist until adolescence, and we may need a revulgarization or valgus osteotomy. And lastly, residual coxa vara may cause compensatory genovalgum. So it is better to be avoided if unnecessary, and if you do varus osteotomy, make it at minimal as possible. Thank you, Dr. Nabil.
Thank you. We shift now to part 4 of our webinar today, is the complications of treatment. As we going on, we are working on clinical scenario cases. You have a girl with two years old diagnosed with right DDH. She underwent an open reduction and immobilized in hip spica, 45-degree in abduction and full internal rotation, and she do an shortening with, after that, removal of the bed, as we see in this X-ray, and follow-up X-ray, immediate post-operative during spica immobilization and after spica removal, or confirmed that she had a successful concentric reduction. At 1 year follow-up, plain X-ray revealed this complete disappearance of the ossific nucleus. I will go to Professor Tariq to comment on this scenario and the X-ray.
This baby, unfortunately, has developed one of the most devastating complications following treatment of DDH. And I mean what I say when I say most devastating, because the other serious complication we will talk about is recurrence. And if you have a recurrent DDH, you still have a good chance of doing a revision operation. But unfortunately, if you have AVN, then most probably you can do nothing, or you can do very little to it. And this hip is doomed to be affected throughout life. When I said that it is devastating, and I also said that it is a complication of treatment, because if you have ever seen a baby, a child, an adult who is now maybe 18 years old with a neglected DDH, you will find that the head is not avascular. It is completely vascular, even though it is maybe a little bit deformed. So it is an iatrogenic complication. Why it develops, we don't know. There are a lot of risk factors, like maybe Dr. Shady will tell us about, but I will not go into them now. But even if you are very aware of them and take good care that you do not expose yourself to these risk factors, you might still end up with this complication. It is irreversible usually, and you end up with a limb length discrepancy, and it's difficult. It's really difficult to manage.
Do you have any suspect reasons for taking place after 1 year? And how can we expect that avascular necrosis could take place for how long time after my intervention?
It might, unfortunately, it might happen. I mean, in my practice, I've seen it happen maybe up to as late as 18 months. But if you read in the literature, it might even happen as late as 5 years. So it is very, very, very unpredictable. That's what I say. It's very unpredictable. It's very unfortunate. And once you have it, you know that this hip is doomed. Whatever you do, maybe Dr. Shady will go through some of the treatment options, but whatever you do, this hip will not be normal. I mean, if you have a recurrent dislocation, then you might tell the parents, okay, don't worry, we'll have a difficult operation, we'll have a difficult time, but at the end of the day, you might end up with a good result. But with this one, no, you know that you're going to have a disabled hip throughout life.
Professor Hani, do you expect that the problem is in the surgeon or in the patient, as a surgeon during treatment or during operative intervention or post-reduction and osteotomy, or it is a problem of pre-operative evaluation of the patient to reach to that?
I think putting the leg in full internal rotation has a role in this area. And I think this is what is clearly expected. We should not put the reduced hip in an extreme position whatsoever. If we have to put it in extreme position, that means that we have either a problem of rotation or problem of reduction. We should put it in mild abduction, mild flexion. The hip should be at ease where after the reduction and stable. If we do not reach this situation, we will have a problem such as this problem. The problem is now, what are you going to do with this case?
Yes.
You can do, if you want to have a stable hip in this age, you can put a fibular transplant, as we have done before. We take the fibula and stick it into the stump of this neck and put the hip in and leave the head to grow gradually. It will grow and it will look like a Perthes disease. If you want to wait, you can wait until skeletal maturity and put a pelvic support osteotomy.
Is there any rule for corrective osteotomy for this girl, or hoping to revascularization of this head as a line of treatment of this case?
I don't think revascularization is the aim here, because you won't find a head to revascularize. But you can put a fibular graft, the head of the fibula. At this age, you can put it in and it will take and it will grow. It will not grow as the other side, but it will grow and it will have a support and it will have a tethered effect so she can walk on this hip. And you can give her a good hip for a while. If she's happy to continue, as we had a series of 25 years follow-up with such cases, and they were reasonably doing well. If you have a problem, you can always go back to pelvic support osteotomy.
Yes, sir. Now we shift to Dr. Shadi, who will tell us what we need to know about this problem and how we can avoid its occurrence from the start. Yes, Shadi.
Thank you,
Shadi.
Professor Nabil. Thank you, Professor Nabil. Okay. Okay. At first, we should have a little hint about the blood supply of the proximal femur, as it depends on the medial circumflex femoral artery. So the proximal femur is highly susceptible to any blockage of this vessel, especially with hip abduction. Okay. Okay. As our professor said, it is a iatrogenic complication. It is caused by surgery. What we can see in X-ray that make us suspicious of this condition is we can see the femoral head delayed ossifications up to 1 year after the operation. Also, we can see widening of the femoral neck within 1 year of the operation. Also, the femoral head may appear sclerotic or fragmented. Also, there may be widening of the femoral head, increased size of the femoral head. Okay. Okay. So what is the outcome of avascular necrosis? Back, please. Okay. Avascular necrosis can lead to limb blades discrepancy and can cause coxa brevia or coxa valga or coxa vara, which may lead to acetabular dysplasia and geotic incongruity, and later lead to avascular to osteoarthritis. Okay. There is a famous theory that's back, please, sir. There is a famous theory that correlate ossification of the head femur to decrease the rate of avascular necrosis. This is a debatable issue, and we will discuss later on. Next, please, sir. Okay. In a systematic review published in the Journal of Children Orthopedic, the author finds that the over rate of vascular necrosis in closed reduction is about 10%, and it can occur up to 7.5 years following closed reduction. Next. In another systematic review published in Medicine Journal, the author found that the incidence of AVN range from 5 to 57% for open reduction versus 2 to 20% for closed reduction. So they concluded that open reduction is considered a risk factor for increased incidence of AVN when compared to closed reduction in patients less than 3 years old. Okay. The current literature, as we said before, that does the ossific nucleus, presence of ossific nucleus, decrease the risk of avascular necrosis? In a paper, in a review published in Journal of Bone and Joint Surgery, they also finds that the current literature does not support the hypothesis of presence ossific, that the presence of ossific nucleus causes reduction of the risk of avascular necrosis. On the other hand, okay, sir. On the other hand, in a research published in Journal of Children Orthopedic, the author found that the femoral head size and not the ossific nucleus is negatively correlated to the risk of avascular necrosis. So the larger the femoral head, the smaller the risk of avascular necrosis. Okay, sir. Okay, how to decrease the incidence of avascular necrosis? At first, avoid extreme position in hip spike. Don't do a hip abduction more than 50 degrees. Next, during operative reduction, if the femoral head is high and it is reduced under pressure, we should do femoral shortening to decrease the pressure on the head. Also, it's important to do adequate muscle release and concentric reduction. Next, sir. In a research published in the Journal of Children Orthopedic, the author finds the degree of hip abduction in the hip spica appears to be an important risk factor for patients less than 6 months, and they recommend limited abduction to less than 50 degrees. Okay. Okay. In another back, please, sir. In another research review of literature, they also recommend avoiding wide abduction and use of femur shorting can decrease much the incidence of avascular necrosis while treating DDH. Okay. So how to treat avascular necrosis? As our professor said before, we can do femoral head transplantation if the head is completely resolved. But if I have overriding greater trochanter, we can do trochanteric epiphysiodesis or trochanteric advancement. In case of Coxa-Vara, we can do lateral closing wedge Vargas osteotomy, which may be combined with trochanteric epiphysiodesis. Thank you, sir.
Okay. Now, I think Professor Tarek has a comment. He has his hand. You want to told us something, Tarek?
Yes, I have. I have two comments. The first one is regarding this patient that we showed the X-ray of. It is very important before making the final judgment is to make an MRI, because actually this particular patient that I have showed on the X-ray, she has complete absence of the ossific of the head on the plain X-ray. But when we did an MRI on her, she has a well-developed head that is totally cartilaginous. So this is very strange. And one of the signs is that failure of the ossific center to grow. And sometimes it's complete disappearance. But when you do an MRI, you find it. And this means that the hip is still stable, and which means that even with time, if you get limb length discrepancy, it will not be very dramatic. And even if it reaches maybe more than 5 centimeters, you can do limb lengthening with a unilateral frame without fear of proximal migration or subluxation. The other comment I wanted to make was regarding the paper that Dr. Shady presented about that open reduction has an increased risk of AVN when compared to closed reduction under the age of 3. I'm not particularly sure whether this study was looking at the classic bikini incision anterior approach of the hip, or it was including patients with the medial approach, because it is well known that the medial approach has a but has a much higher incidence of AVN when compared to the open reduction through the anterior approach. Thank you very much.
Thank you, Tarek. Now we shift to another scenario with a girl 16 months old, and she went under open reduction for right developmental dysplasia of the hip. And during intraoperative evaluation, there was concentric reduction achieved perfectly, and this was confirmed by an image intensifier. And immediate post-operative, after discharging from the theater, a plain X-ray revealed dislocated hip. So, in short, the subluxation or dislocation immediate post-operative. How would you proceed, Professor Ali Ibrahim, for that?
I think the problem in this case may have happened because of some points which Professor Tarek mentioned before. Maybe the transverse ligament was not excised or cut. Maybe the acetabulum was not properly cleaned. We have to exclude that the hip is dislocated during application of the spica. This should not happen, actually. And the concentric reduction during surgery should be very easy. It should not be done under force to avoid such a complication. In that case, if this is seen immediately after the surgery, we have to change the cast under general anesthesia, and again, image intensifier should be used to be sure it is a concentric reduction.
So
some
you said
authors,
we have.
Yes.
Continue, sir.
Some authors may go on for open re-reduction. And to avoid missing instability arising factors there, like transverse ligament or iliopsoas tendon or vulvar
assuming that, Professor Ali, you are the surgeon who did, and you do remove all the obstacles for concentric reduction, and
I have to change I have to change the cast under general anesthesia. Yes.
Okay. Do you put in mind or think that maybe a supplementary K-wire fixation to restore the head?
We can do this. Yes, we can do this. We can do this.
Okay, Professor Hani.
It will not be dislocated. Yeah.
Professor Hani, I think you have another opinion, and you should tell us why that took place.
I think if the hip was reduced nicely during surgery, most probably the problem is during lifting the child to be put in the spike. And this can be really important to look after. You have to lift the baby. One can lift the head and the spine and the back, and another one should lift the trunk, and one on each leg. So you get a proper movement for the child to be put in a spike. Provided that the surgery was done and it was really concentrically reduced.
What were next line treatment? What do you do next? She's now subluxed or dislocated.
I would put her on, I would change the plaster on GA.
Okay, like Professor. This one of questions sent to us tonight from one of our colleagues about what we will do after subluxation. I think this answer now reached to him. Tariq, do you have any other opinion, Tariq, that you will go to close reduction, change of spike like Professor Alan Turani, or you proceed for reopen reduction and doing something else?
No, I believe that this immediate post, we have to differentiate in recurrent cases between immediate or early and late. Each one of them has its causes. So this is an immediate dislocation.
Please, on this case, because we have the delayed one, next one.
Yeah, I believe that in this one, which is the immediate dislocation, redislocation, like Professor Haney says, I am nearly almost 100% sure that it is caused during lifting the baby and applying the spica. So this actually should have been detected immediately, because what we do is that after at least 4 people should attend the application of the hip spica. I always believe that there are 3 very important steps during the open reduction. One of them is the cutting the transverse acetabular ligament, because sometimes you have to do it blindly. The second is during the capsulorrhaphy, because you have to get your flaps right. And the third is application of the cast. So you just can't go away and leave your assistants to apply the cast. We need 4 people to be present during application of the hip spica. And after we finish the hip spica, we should get an AP and the lateral view in the hip spica. And it's very easy now. We are trained to do the lateral view in the hip spica by putting the baby on the operated side and maybe tilting the baby just a few degrees to get the other leg out of the way, because we usually do 1.5 spica. And you need to get that nice view when you see the ischium on its dead lateral border, and you see the acetabulum, and you see the head pointing towards the triradiate cartilage. It's only then that I am happy and I go and drink my coffee. So the answer to this question is to do an immediate close reduction. And to answer your argument about using a K-wire, I totally disagree, because the wire is not any good for stability. If you have any obstacles for reduction and you depend on the wire, you will end up maybe a few days later with the hip again dislocated with the wire in. So we have to depend really on the concentric reduction and applying the spica in the correct position.
Okay, and we shift from your last word that we have another delayed subluxation or dislocation after everything is okay. The girl is 2 years and she was operated, and intraoperatively she has concentric reduction is achieved, and immediate post-operative CT scan even done and she had concentric reduction of her head, but follow-up CT after 2 weeks revealed dislocated hip. How can we proceed for that, Professor Hani? First case, we decide to do change of cast under anesthesia. Now, she is 2 weeks later post-operative. How could you manage this?
Sorry, who are you asking, Professor Nabil?
Professor Hani.
Yes.
Professor Hani.
Yes.
You heard me about this case?
2 weeks post-operative, and it
2
was
weeks, yes.
very
Yes.
well reduced. I think
Yes.
it's a rotation problem.
Yes.
I don't think this was reduced nicely from the beginning. It slipped. Slipped means that either the posterior part of the acetabulum is deficiently markedly, which is not the common, but the common thing is that it was put in not a very well reduced position.
So these are the causes. What is the next step? Do you return the girl back to the operating theater and do something there?
Yes, I would redo the operation and make sure that the rotation of the limb is okay and the reduction is reasonable. Stable.
Okay. Okay. From the X-ray, Professor Tariq, I see that the surgeon did not do any shortening of the femur. Could be this a cause of this recurrence of subluxation because an X-ray is available in front of you and there is no shortening or any form of osteotomy. Could be this is the reason for that? Is it neglected to do femoral shortening?
No, my opinion, first of all, if we look at the immediate post-operative lateral view and the immediate post-operative CT scan, it is very well reduced. It is concentrically reduced. I believe that the reason that this hip dislocated 2 weeks later is an error in the steps of the operation. So maybe going back to what we said before, maybe the surgeon didn't divide the transverse acetabular ligament. Maybe he didn't clear the acetabulum of all the pulvinar inside. Maybe the capsulorrhaphy was not done correctly. Maybe the flap.
You are the surgeon, Tariq. Tariq, you are a surgeon and you did all of that. How can we treat this case?
I'm a surgeon, and even though I'm confident that I do all the steps every time, at one time you might have a mistake. You might.
Yes, of course.
I will go back in and I will do an open reduction.
Again. Well, yes. What about the capsule and the vascularity of the femoral head at second exposure of it?
No risk at all. I will not use any force. All I will do is that I will simply go in the planes. I will just open the planes and then I will remove the stitch of my capsulorrhaphy and then I will have a second look inside the acetabulum. If there are any obstacles, I will remove them. If there is any part of the transverse acetabular ligament still not divided, I will divide it. And then I will redo my capsule with heavy sutures. And then this is the only time when I might be tempted to protect myself with a wire.
Okay. Thank you. Now we shift to Dr. Shadi, who will tell us what we need to know to avoid this complication, either subluxation or dislocation as an important complication of that. Yes, Shadi.
Thank you, Professor Nabil. We all know that recurrent subluxation or dislocation may be caused by inadequate reduction from the start or failure to maintain concentric reduction. Okay. The incidence of occurrence is 3% if the operation is done through anterior approach and up to 14% if done through medial approach. Okay. Okay, sir. As you can suggest that risk factor for failure after open reduction of DDH can be summarized in maybe due to the appearance of DDH in the right side or in bilateral cases or greater pelvic width or decreased hip abduction in hip spica and increased femur anteversion. Okay, sir. Other risk factor that may affect the dislocation is inadequate soft tissue release, as Professor Tariq said. and in case of which increase the incidence of redislocation if we did not did intra-articular release, especially for transverse acetabular tendon, for ligamentum teres and transverse ligament. Next, sir. Okay. Okay. In a paper published in a journal of orthopedic, the authors stress that the experience of the surgeon as the technical factor play a very important role in preventing early dislocation. And they found that the absence of civic center was has a higher incidence of redislocation, but it was not statistically significant. Okay. In another paper published in the Hip International Journal, the author found that high total anteversion of the femoral head and the sternum is the main cause of redislocation. Also, he found that there is no significant difference in terms of acetabular inclination angle or cervic nucleus diameter and pelvic side or pelvic width or central edge angle or acetabular volume. They recommend correction of increased femoral anteversion by femoral osteotomy in association with pelvic osteotomy to increase stability of the joint. Okay, sir. Okay. Some surgeons prefer to classify the reason for failure of reduction into immediate causes like dislocation during application of spica or associated pelvic osteotomy or femoral osteotomy with open reduction. Some surgeons prefer to postpone the femoral osteotomy or pelvic osteotomy to another operation after 6 weeks. Okay. Okay. Also, the reason for delayed failure may be inadequate soft tissue release or inapproved capsulorrhaphy. Okay. Okay. The first question we have to answer: when to do revision operation? If the redislocation is discovered early within the first 4 weeks, immediate intervention can be done. But if redislocation is discovered after more than 6 weeks, it is better to wait to give a patient a period of freedom from the hip spica for the mobility to return, and then we can do revision surgery after 6 week promotion. Okay. Okay. The first thing to do is to maintain a constant reduction during the operation. We cannot do pelvic or femoral osteotomy without the hip placed well inside the acetabular. Unless this is done, we cannot maintain reduction. What to do inside the operation? As we did as open reduction normally, we release intra-articular obstruction, especially transverse acetabular ligament, ligamentum teres, and we remove the pelvinar. And if the acetabular labrum is inverted, we can do radial cuts in it to invert it. If the hip is still high, we can do femoral shortening to reduce the hip without any pressure on it inside the acetabular. Some also prefer to do femoral anteversion in a next operation, in another operation after about 6 weeks. But other surgeons prefer to do it in the same setting if it is required intraoperatively. Okay. Of course, capsulorrhaphy is an important step to be performed with heavy sutures. And if the hip is still unstable, we can place Q wires to just maintain concentric reduction. Of course, the patient is immobilized in the hip spica for about 12 weeks. Okay.
Thank you, Shadi.
Sure. Thank you.
I want to ask Dr. Tamer Fayad about his personal working on the patient with the recurrent case after 6 weeks. What you can face during reduction or during manipulation of the bone after recurrence, after doing an operation 6 weeks, you will decide to do an open reduction and femoral. What about the quality of bone you may face during the operation?
Okay, so this problem I have faced many times. When doing a stage operation for DDH, starting with open reduction and femoral osteotomy 6 weeks later, what I have found that the bone quality is very weak. Sometimes I cannot hold the osteotomy by the blade. So from my personal experience, I stopped doing a varus dilatation 6 weeks later. I do it at the same session with open reduction.
Okay, but what about if the case after complete reduction, it is dislocated? How long time you will leave her to redo the operation? How long?
Maybe I will wait for a few months to give the child a chance to start walking and start regaining some muscle activity, then do the operation again.
Okay. Sometimes you may do an over closure of the capsule, and the capsule may be very, very tight during closure, during capsulorrhaphy, and may subluxate or dislocate the head posteriorly. Do you advise to remove part of the capsule, like we said now, capsulectomy, partial capsulectomy, and do capsulorrhaphy not too tight during the operation?
Okay, sir.
To avoid that?
I don't close the capsule very tight, especially when I'm doing some sort of femoral osteotomy at the same session. Because yes, if I did a tight capsulorrhaphy and a femoral osteotomy, it will likely be dislocated posteriorly.
Okay, thank you. Thank you, my colleagues. Now the last part of our webinar tonight is the late presenting cases. And we start to present a 6-year-old girl with left developmental dysplasia of the hip presented to your clinic, and the parents admitted that apart from limping, the child with no pain and has no disability. And this X-ray done for her by you. Please, Professor Hani, can you tell me how can you proceed for treatment of such girl?
Thank you for asking me, Dr. Nabil. Now, this is a dislocated hip in a 6-year-old?
Yes.
Fine. I mean, this is not a very high dislocation, can be reduced nicely. An open reduction will be fine, but we have really to understand that reducing the hip should be done without pressure and without extreme angles, flexion, severe abduction, severe internal rotation. We have to get this right. So the hip should be reduced and rotation should be stabilized properly, as well as a proper capsulorrhaphy. That would be enough in such a case. Mind you, I want to stress this again because there's a lot of studies going on now with the closed reduction in such cases. This was done by Papeliou, Nicholas Papeliou in Greece, and this was done for 10 years now with a good results. He uses a modified Hoffman-Daimler technique. In our experience, I would do an open reduction if needed, a femoral shortening. But I don't think this will need a femoral shortening, but this should be assessed during surgery.
First of all, we agree that we may need, if we decide to do open reduction, femoral shortening. Do you advise to do all the steps or to obtain concentric reduction at once or staged?
Yes, I would do all together. I would
go together in this case.
It is well reduced and stabilized. I wouldn't wait for another session. I would go straight away, do everything at the same session, go outside, and everything is settled.
For the same case, please. Do you agree with that, or do you have another opinion?
Sorry?
Professor Ali.
Yes, I actually agree with Professor Hani. This is not very high dislocation. It can be reduced by open reduction. we may need to do derotation varus osteotomy. And in some cases, especially this case, I think there is dysplasia of the acetabulum. So we may need to do acetabulum or pelvic osteotomy. We can delay it after 6 weeks.
Yes. But you know from this figure, Professor Ali, that the girl is walking without pain, limping only, and has no disability.
Because it is unilateral, it should be treated.
Yes, that's what I want to know.
Yeah.
Tariq, do you agree that you proceed for all the steps in the same set, or you do staged operation for the girl?
First of all, whenever I get a DDH in a child who is older than 4 years old, I'm very, very concerned about the outcome. And I spend a lot of time with the parents explaining to them that I cannot guarantee the outcome. Because we have to remember that whether you have a unilateral or bilateral high or low dislocation that is neglected after the age of 4, and the older the child is, the more relevant my points are, is that you might get a very good result on the X-ray, which is detected by the what we call the Severin classification, but you might end up by a very not good or very not satisfactory clinical outcome, as we know by the McAfee or the McRae clinical classification, which, I mean, you might get a reduced hip on the X-ray, but it's stiff clinically. So the child is suffering. So I'm very reluctant, but definitely unilateral, 6 years old. I also take into consideration the baby's weight. So if the baby's weight is of the average weight, and it's unilateral and it's not very high, then I'm definitely not going to hesitate to operate after explaining to the parents the possible outcome of stiffness. And then, but I would agree with Professor Ali Ibrahim and Professor Hani Hefni that we are going to need open reduction. We will not need femoral shortening. We will need a derotation osteotomy with very minimal or no varus. But I believe in staged procedures. I will do an open reduction, and then 6 weeks later, I will do my derotation osteotomy. The reason for this is that there is a lot of evidence from the literature and also from my personal experience that if you do combined open reduction with a femoral osteotomy, what you end up with is jeopardizing your capsularity, because you end up with the proximal femur as a loose piece of bone, and you cannot stabilize your joint. So I do the capsularity, and then 6 weeks later, I go in and do my varus osteotomy. And the point that Dr. Tamer mentioned about the bone being osteopenic is very relevant in young children and in paralytic dislocations. That's why I've stopped doing any femoral procedures under the age of 3. But in a 6-year-old, if you do an open reduction and put her in the hip spica for 6 weeks, then you will not have any problem of osteopenia, provided she's not paralytic and she's not young.
Okay, that's what happened. What was done for the girl. She underwent stage open reduction. Then 6 weeks later, she was operated by VDO with minimal varus osteotomy to contain. And here, against Tariq rule, there is a key wire put in the hip to maintain the reduction. I don't know why. Next, she had an excellent clinical and radiological outcome. This is an X-ray for the girl, as you see. And this is a clinical photo of her with very good range of abduction, no limb length discrepancy, as you see. And she's walking after the operation. Okay. Next scenario, we are another case, but with the same problem, with the left hip dislocation, and she is 6 years old, and this X-ray showing that the hip dislocation is very high. Is there any other rationale or procedure you may ask to do, Professor Hani? You said that the first one is not highly dislocated and we can do open reduction with or without femoral shortening. But this one, the plan of treatment will be different because it is high. Your opinion, Professor Hani?
Well, it's as you said, it's high. So femoral shortening is definitely needed. There's no doubt about this. But I would like to assess the acetabulum a little bit more.
Yes.
Because it might need a pelvic osteotomy of somewhere. So I would go all, I don't believe in staged surgery. I would go and do everything at
all
the
in
same
one.
time.
All
Yes.
in one.
Yes, yes. It's one surgery.
Yes.
Use the hip shortening, get the rotation right. If you have a problem with the cover, you cover the side with the head, you cover it with the pelvic osteotomy. Do a proper capsulorrhaphy. And if you're trained to do this, you have no problem doing the capsulorrhaphy after the reduction. There's no problem at all.
Yes, sir. So I shift to Tamer because I want to ask you one very important question. You do an open reduction and the head is contained. How can you determine the need for femoral or pelvic osteotomy intraoperative? You decide to do open reduction, you did it, but the head should be contained perfectly. You hear me? How can you decide which of osteotomy we need, femoral or pelvic, or no need at all?
Okay, sir. We have what we call the test of stability, meaning that
yes.
Which position the head is stable in. If it is stable in neutral rotation and full extension, so we don't need any additional osteotomy. But if it is contained in internal rotation and abduction, so we need a VDO. If it is unstable in extension and it tries to subluxate anterior, mostly we will do an additional pelvic osteotomy.
Okay, thank you, Tamer. Okay, she underwent open reduction, femoral shortening, and 6 weeks later, stage 1, she underwent VDO. And this is the opinion of the surgeon, but Professor Hani told us that he can do all in one according to his experience. This is the immediate X-ray post. She had an excellent clinical and radiology, as we see. I think the same video. Okay. Another very important clinical scenario, we discussed the unilateral hip dislocation neglected at older age with unilateral side and limping without pain and disability and unilateral case. What about the cases presented at age above 6 years and presented with bilateral neglected DDH? And the parents are always concerned about the diagnosis and the future implications of the girl. They ask if we can leave her or operate her. And this, for example, the presentation of our girl. You see, you can see she has a waddling gait, she has wide perineum, limping, painless, with excessive lumbar lordosis. Okay. And this is the photo clinical and radiological of the girl. The concern now is the case is neglected. She's 7 years old, and she has bilateral equivocal DDH on both sides. What we can do, Professor Ali?
Well, I will go for staged surgery to one side and staged surgery for the other side, but I have to stress to very well clarify the prognosis and the expected problems to the parents. And I believe the choice to them. If they decide to operate, if they decide to operate, we will do staged left side, then staged right side, the long time for treatment, the guarded prognosis and outcome, and the other thing, the asymmetrical results on one side from the other side. Sometimes one side is having a very well reduction and growth and asymptomatic, but the other side will show some problems. Then the child will start, yeah.
So you decide, first question is to decide to do or not to do. You decide to do, and you will start to decide to do staged surgery,
yes.
one side by one side.
One by one.
Okay.
Yes, but,
okay.
but it should be very clear to the parents about the prognosis of the case.
Professor Hani, you agree that, or you have a, you decide to leave the girl till maturity?
I wouldn't leave the girl. I would do the open reduction and whatever is necessary, femoral shortening, pelvic osteotomy, capsulorrhaphy, get the hip reduced, spica, and the other one is next. I would leave sometimes before the two surgeries. If we're going to start with the right side, after we finish the right side, get the full movements from the right side to the other side, left side.
But if you another one decide to leave the girl without any intention, what is the prognosis for her? What is the problem later on?
Well, this this problem that this girl maybe, we don't know when, maybe when she's 18, 19, 20, maybe when she's 30, we don't really know when. She might start to have some problems. Interestingly, she will not start to complain of her hips. She will start to complain of her back first because of the increased stresses on the back, particularly in unilateral cases, but even also in bilateral cases. So it's a really very tricky situation to make up your mind, and this is one of the very few situations where I am not able to give my answer to the parents, should we do the operation or not. And like Professor Ali said, we should explain to them and give them the opportunity to share in the decision making. I know it's not fair sometimes because they want you to tell them what to do, but unfortunately we do not have enough evidence in the literature of the outcome. But if the parents say, okay, we want to take the risk or take the chance, then I will go in and I will do it, and I will do it in a staged procedure, and I will do the open reduction and the femoral shortening in one stage, and then go in 6 weeks later, do the VDO, and then leave the baby out of the cast for at least 6 weeks to get the hips mobilized and the osteopenia over, and then go in and attack the other side and the same side. And you're really concerned about the possibility of asymmetric results sometimes.
Okay. Tamer, do you tell me
in brief يا دكتور نبيل عشان التايم لو سمحت.
Time, the last we last session, Professor Amr.
Yes.
Tamer, you decide to do both sides. Do you agree with our senior professors that you do each side at the same time or staged?
No, I prefer, sir, to do it at the same time.
Okay, but to actually
May I add something, Dr. Nabil?
Yes, of course.
As Professor Tariq said, and Professor Ali said, that we have to explain everything.
Yes.
We have to tell them that at some stage, if she's not happy with this result, there's another operation can get her walking at the age of puberty, which or whenever she has pain, which is a pelvic support osteotomy, and this should be clarified from day one. So everything should be clarified to the parents before surgery.
Okay.
Thank you very much.
Thank you, sir. And I will show the figures of the girl now rapidly because we pass time. This is the girl before the operation.
لا دي ريزلتس بتاعتها
ايوه
بعد
results ساعتها بعد العمليه سوري
بعد one side was done.
Okay, never mind. The last clinical scenario tonight is the same problem, and I will passing rapidly on the photo of girl with bilateral DDH as we see, and this is the clinical and radiological data before the surgery, and this her gait. And decide to do what we are all agreed about the stage treatment for, and then this is before this is one side done and the other side prepared to be operated as time of the operation.
This is the result of the left side.
Yes, she was operated the left and waiting for the right Tara? Okay,
yes, now she's yeah,
prepared for doing the right side.
Yeah, exactly.
And this is the X-ray post-operative for both sides. CT scan. Okay, now last talk presented with our colleague Tamer about what we need to know about these cases presented late after 6 years. Yes, Tamer, please.
Okay, sir. Okay, we are faced with a great problem this age, above 6 years. We have a certain debate whether to interfere with these cases or leave it alone, do it a one stage or a stage surgery. The problem with these cases is that it is a long-standing case, meaning that we have already some sort of changes in the anatomy and the osteology and on the soft tissue. Usually these cases has a very large head, a very small and shallow acetabulum, some sort of muscle weakness or muscle dysfunction. Next, please. So if it is left untreated, we are faced with a limping child or a limping adolescent. And it will lead to a progressive disability that will leave the patient crippled early in life. The aim of the treatment here is somehow different. We are not aiming at attaining a fully functioning hip or a fully normal hip. We are aiming, after the reduction of the head, is to regain some sort of normal anatomy to facilitate later management and to some sort of improve the way of walking. We are faced with two situations, unilateral cases and bilateral cases. In unilateral, we have to interfere. But in bilateral cases, this is a great debate because around the age of 6 years, we are faced with a long time to finish this patient. So the patient has to understand the problem and what we are facing. Next, please, sir. Next, sir. The problem of stiffness is very great. So this is a state-of-art review article that stated that between the age of 3 and 8 years, we have the option of open reduction with or without femoral shortening and with or without pelvic osteotomy. And above 8 years, we have two options. Either we do the same or neglect the patient. Next, sir. This is a literature review. A one-stage hip reconstruction is what I found. Mostly the work done on the one-stage reconstruction, including all the steps to be done at the same session. They pointed out a very clear point that if we need shortening, we do adequate shortening. We don't depend on the degree of varization to present a part of shortening. Shortening is a part and varization is a part. Next, sir. Another another paper talking about the late diagnosed bilateral DDH. They told us that the results will be better on the first operated hip, but there is a great concern in the bilateral cases that the outcome may not be the same. Next, sir. Surgery before the age of 8 years in the unilateral cases and before 5.5 years in the bilateral cases is the recommended age of interference. However, the age and unilaterality or bilaterality is not an absolute criterion for the decision making. It should be tailored according to each case. At the end, despite this substantial research, high quality comparative studies are lacking between the different types of treatment, and at the end, it is according to the experience of the treating surgeon. Thank you, sir.
Thank you, Tamer. Thank you, my panel and my colleagues, my speakers, about this nice webinar. Before we end, I have 3 questions only, but I think we answered it during our webinar. As regards the intraoperative stability, as regards the K-wire temporary fixation after open reduction, as regards K-wire fixation after close reduction and before hip spike application, and as regards there is any rule for traction. I think all these questions was answered during our presentation. I hope it was an interesting webinar. All of us are enjoyed. And
thanks, Dr. Nabil, very much. Thanks very much. وثانكس للاودينس اللي استحملونا لغايه الساعه 11 و10 تقريبا. And I'd like to express my deepest gratitude to the panel, all the panel. دكتور علي ابراهيم، دكتور هاني حفني، دكتور طارق حسن. حقيقه يعني most to our professional moderator دكتور نبيل غالي for his perfection in moderating this session. Also, I want to bring many thanks to our speakers, Dr. Ahmed Saeed, Dr. Tamer Fayyad, and Dr. Shadi Al-Bishri. Many thanks. Special thanks, of course, to Elixir, شركاء النجاح دائما. وفي طبعا لازم أشكر بشدة very special thanks للمايسترو للإيفنت دوت اللي تعب جدا خلال أسبوعين 3 اللي فاتوا، دكتور طارق حسن، اللي كان ليه الفضل في خروج هذا الإيفنت إلى النور. بشكركم جميعا، وان شاء الله الاسبوع الجاي عندنا ايفنت يعني هيكون انترناشونال وهيكون ممتاز جدا للناس بتوع السباين. ان شاء الله يكون في حالات مثيره جدا، ويكون في يعني اعتقد حضوره هيكون مفيد لمعظم الناس. بشكركم ومتشكرين جدا، وان شاء الله لايفنتس قادمه على البلاتفورم بتاع عين شمس. متشكر جدا، السلام عليكم.